So for our next talk, we have Dr. Schneider from Mary Bird Perkins Cancer Center. Dr. Schneider is the Adaptive Radiation Therapy Technical Director. He's a medical physicist with Mary Bird Perkins, and his talk today will be on MR-guided online adaptive radiation therapy. So we're going to change gears for a sec. Dr. Schneider?
All right, hello everybody. So thank you, Dr. Satakis. My name is Chris Schneider. I'm a medical physicist at Mary Bird Perkins Cancer Center and the Adaptive Radiation Therapy Technical Director. And I'm going to talk to you about a new, MR-guided radiation therapy. I have no relevant conflicts of interest to declare. Maybe one day I'll be interesting enough to have a slide full of disclosures, but so I figure the name of this conference is CAGLA, so I want to put the law in CAGLA. I am born and raised in Louisiana, and I'm very proud to work at Mary Bird Perkins Cancer Center. We have 7 radiation therapy centers in addition to medical oncology and other other types of clinics, but 7 primary centers where we do radiation therapy, 6 in Louisiana, 1 in Mississippi. We operate as a freestanding, not-for-profit cancer center. We have 11 medical physicists. 10 of us are therapy medical physicists. 1 of us is an imaging medical physicist. 6 out of the 11 of us have adjunct appointments in the Department of Physics and Astronomy at LSU. We also have 4 physics residents as part of our training, in addition to our mentoring of students, graduate students in the LSU physics program, and 1 medical physics assistant. And our physicians belong to an independent radiation oncology group called SALROG. We offer a wide range of radiation therapy services. So external beam radiation therapy delivered with linear accelerators. We have 11 across all of our enterprise. We do stereotactic radiosurgery, single fraction treatments for brain metastases on our Gamma Knife Icon. We do brachytherapy, both high dose rate and low dose rate for GYN cancers and prostate cancers. And we do theranostics, including Pluvicto and Xofigo. The start of MR-guided adaptive radiation therapy at Mary Bird Perkins Cancer Center, we kicked off the program on December 11th, 2023. The number of unique patients in the first year was 167, which is, in this field, that's a really, really fast ramp up for a program, and we're going to easily surpass this now as we're partway through our 2nd year. We've treated up to 14 patients a day, and the current average patients treated per day is 8. We've managed to bring that number down from 14 to 8 through pushing more toward SBRT, so hypofractionated treatments, patients who would normally receive 28 fractions or 35 fractions of treatment on a conventional course of radiation therapy. With our MRI LINAC doing MR-guided adaptive radiation therapy, we can get that down to 5 fractions or 3 fractions. We also, I'll talk more about this in a bit, we just released tumor tracking, but I'll save that for the end. This is the Mary Bird Perkins physics team, our adaptive radiation therapy physics team. Dr. Satakis is our chief of physics. I also work with Dan Neck, our director of clinical physics. Myself and Jennifer Vos is one of the medical physicists on our adaptive team. And Dr. Crystal Kirby is our imaging physicist, our MRI expert. But it's not just physics. We have a broader team. We have 3 radiation therapists who work specifically in our adaptive radiation therapy program. 1 nurse that serves the program and helps with patient prep and things like that, as well as our CT and MR simulation staff that we do our initial plannings, help us with our initial planning scans, and then our wide range of physicians and nurses and medical assistants. Dr. Kaz Covington is our medical director of adaptive radiation therapy. So just to tap into a little bit of the history of adaptive radiation therapy. It's not a new concept. The concept has been around for quite a while. A paper from 1997 by Yan et al. Coined the term adaptive radiation therapy and specifically the acronym ART. And they described it as a radiation treatment process where the treatment plan can be modified using a systematic feedback of measurements. Right, conventionally in radiation therapy, a patient comes in after having been diagnosed and gone through a consult. They receive a planning scan. That planning, we spend a lot of time crafting a treatment plan for that specific patient based on that planning scan, and then that same plan is delivered over the course of several weeks, typically without being modified to account for any changes in the tumor or in the surrounding anatomy. And for a long time, it's been a topic of discussion and interest. You know, what could we do? What could we achieve if we were able to quickly modify treatments to account for changes in those things during the course of treatment? There are different flavors or different levels of adaptive radiation therapy. Every radiation therapy center pretty much has done some version of adaptive radiation therapy, even if they didn't call it that. Offline adaptive radiation therapy, if you discover during the course of treatment from, say, pre-treatment imaging that a tumor has significantly grown or a patient has, we weigh in our patients when they come for treatment if they've gained or lost a significant amount of weight that we believe will have affected the geometry, we might halt treatment and send that patient to be re-scanned to do a new plan to account for those changes. And that is offline adaptive radiation therapy, which has been around for a while. But online adaptive radiation therapy is really what the field has been pushing toward. This is where we can update the plan during the treatment time slot while the patient is on the table in the treatment position. We can account for things like differences in bladder filling day to day, gas in the rectum, or if the patient ate something different for dinner, GI structures. As a physicist who has a lot of experience looking at and reviewing radiation therapy treatment plans, I've been surprised at how different the internal anatomy is day to day every time a patient lays down on the table, and it's significant. And now we have the ability to account for that. Frequency with online, we are for many of our patients adapting their treatment plan, thinking our treatment strategy as often as daily while they're on the table. Finally, there's real-time or dynamic adaptation. This is where you update the plan during delivery, meaning in the middle of a treatment while you are irradiating a tumor, you can account for changes in patient position or anatomy from things like respiratory motion or peristaltic motion from things like a patient swallowing. And for a head and neck cancer patient, we instruct our head and neck cancer patients not to swallow, but if a patient swallows with real-time adaptive radiation therapy, we can see that and pause or somehow modify the treatment to account for it in real time. What type of adaptive radiation therapy you can achieve in a clinic is going to depend on what tools you have available. Offline adaptive is pretty much achievable everywhere. If you have the ability to create and treat a radiation therapy treatment plan, then you have the tools you need to replan a patient in the middle of treatment. But online adaptive requires diagnostic quality, which is sort of a buzz term, but you need imaging capabilities on your radiation therapy treatment machine that far exceed that of typical conventional medical linac in order to really be able to identify changes in patient anatomy and account for them. You need fast methods of treatment planning and quality assurance to actually adapt the treatment plan to account for those changes, and you need the staff to do it all, right? Like radiation therapy treatment planning typically involves a team of people, whereas during treatment, conventional treatments, our radiation therapists handle pretty much everything themselves. Well, now that we're replanning, we need to bring the rest of the radiation therapy team to the treatment machine so that we can all be available to update a plan on the fly. And then for real-time dynamic adaptive radiation therapy, you need cinematic imaging of the target or a surrogate for the target. And even better if you can also image the surrounding organs that you're trying to spare and protect from the radiation. And you need a trustworthy feedback loop with the machine. So what solutions are currently available for online adaptive radiation therapy? The vast majority of radiation therapy patients these days, when they come in for treatment and lie down on the treatment table, they receive what's called a cone beam CT scan. So this is, instead of a fan beam geometry that you would use for a, conventional CT or diagnostic CT, the treatment machine, which includes, a linear accelerator that can deliver a megavoltage beam to treat cancer, will also have a KV, a kilovoltage X-ray generator, and an imaging panel, so that you can take projection images, or you can rotate and do some tomography to get a 3D image of the patient. But these images are not anywhere near the quality of a fan beam CT. There are some solutions on the market. The Varian Ethos is one that uses an AI-driven adaptive reconstruction algorithm to get a planning quality scan from a cone beam CT. The other major linear accelerator manufacturer, Elekta, has a new machine called the Evo that is currently only available in Europe. It's awaiting FDA approval for the United States, but it can produce planning quality CBCTs also using artificial intelligence and iterative reconstruction methods to improve the quality of the image. But sort of by the other side of the coin of online adaptive radiation therapy is MRI-guided adaptive radiation therapy. And there are a few competitors in this market, two major ones and one that's sort of an upstart. ViewRay is a company that started specifically making an MRI-guided radiation therapy device. Initially, it was a cobalt-60 unit that used cobalt-60 as the source of their radiation, but then they switched to their Meridian, which it's a low-field MRI, so 0.35 Tesla scanner, and it has a 6 MV, 6 megavolt, flattening filter-free radiation, a linac that produces a 6 MV FFF radiation beam. Elekta, who was mentioned before, released shortly after ViewRay released the Meridian, Elekta entered the market with their Unity MRI linac, and this is a high field MRI, a 1.5 Tesla MRI, so the most common magnetic field strength for a diagnostic MRI, and they combine that with a 7 MV triple F beam, so it's one more, so it's just a little better. It's just I'm not really sure why they made the choice to go with 7 MV instead of 6 MV, which is more common. But and then finally, there's a Canadian group, Magnetics, I think is how they would pronounce it. They have the Aurora RT, which instead of being a conventional closed bore MRI, their system is based on a biplanar MRI with 2 flat magnets. That gives them the ability to do some different things. But it's also a low field MRI, 0.5 Tesla. So Elekta Unity currently the only one on the market that's offering 1.5 Tesla MRI linac combo, which allows them to do some things that their other machines can't. What's the general rationale for MRI-guided adaptive radiation therapy? Well, compared to other machines where we're setting up our patients based on planar X-rays or sort of crude computed tomography, crude CT images, MRI offers by far superior soft tissue contrast. So for sites in the pelvis and in the abdomen, maybe sites in the thorax, especially if maybe lung cancers that are invading the mediastinum, the ability to visualize the tumor on a treatment machine that has onboard MRI imaging is just far superior to that of a machine that's relying on X-rays or cone beam CT. Additionally, MRI provides the capability for real-time cinematic imaging, meaning that we can image, we can do a live updating image while we treat to track tumor motion or patient motion look for any changes in the geometry that we might need to pause treatment to account for. Additionally, MRI has the benefit of not adding any ionizing radiation. So radiation therapy, even though imaging, the doses from CT scans are much lower than the therapeutic doses of radiation that are delivered during a treatment, it's a much greater volume of tissue that's being exposed to X-rays in a CT or a cone beam CT that we use to set up patients. So MRI is great because we can see all of the tissue we need, both near and far from the target that we're treating, without adding any additional ionizing radiation dose. And MRI also gives us the ability to perform functional imaging that can be used for a really hot topic right now in the adaptive radiation therapy research community, things like response assessment. So instead of having to, if we want to do functional MRI imaging of a patient, whereas for a conventional machine, we would have to schedule those patients for a separate appointment. We might not be able to do it every day. We might only be able to send them for a functional MRI scan once a week. With the Elekta Unity being a 1.5 Tesla scanner, we can do diffusion-weighted imaging for our prostate cancer patients, and we can run those diffusion scans while we're treating, so it doesn't add any time to the patient's treatment schedule. And then theoretically, we could use the results of that functional imaging to guide future fractions of the treatment to determine, based on how effective the therapy seems to be. As I mentioned, we treated our first patient at Marybird on December 11th, 2023. We have treated many different sites. So in the pelvis, we've treated prostate. We've treated gynecological cancers, bladder cancers, primary bladder cancers, primary rectal cancers, as well as metastases to lymph nodes or bone, individual bone metastases. In the abdomen, we've treated, we're seeing a lot of benefit for liver patients, pancreas patients, kidney patients, or adrenal tumors, as well as mets to the lymph nodes and other things in the abdomen. And then in the thorax, we've treated lung patients. Specifically, the primary benefit so far has been lung patients where the tumor is invading the mediastinum, so that you wouldn't really be able to see the tumor very well on a cone beam CT if it's invading other tissue of similar density, but on MRI we can. We've done spine SBRT on our machine, and then we also treated a heart sarcoma. Is one of the sort of more exotic or rare sites that we've treated. So at Marybird, we have the Elekta Unity MRI Linac. So just to sort of give an idea of the technology that goes into this sort of treatment, I'll focus on that since that's what we have the most experience with. The Unity is like I said, a 1.5 Tesla Philips MRI that has very minor modifications. In most respects, it is identical to a typical Philips diagnostic MRI scanner. Around the cryostat, so around, if this is the annulus of the MRI where the helium is there for cooling to keep the system superconducting, there's a drum, a large rotating drum that's built around the outside of the cryostat that houses the linear accelerator. And we deliver the radiation beam right through the cryostat. The cryostat's slightly modified, so the helium annulus is made a little bit narrow in the center so that we're not shooting through as much material to get to the patient. But it's really, pretty impressive design. The Faraday cage, which in a typical MRI vault is going to be just built into the exterior walls of the MRI imaging vault, in order to isolate the linear accelerator from the magnetic field of the MRI and to isolate the MRI from any RF interference or noise from the linear accelerator or the motors that drive the drum. It's a custom Faraday cage that's built specifically for each site that sort of cuts out and isolates the LINAC from the MRI. So the patient, is the cryostat and the patient are inside the Faraday cage in the imaging suite, and then the LINAC is technically out, even though it's sort of built all around the MRI, it's outside, isolated by that Faraday cage. The magnetic field, this prevents the magnetic field from disturbing the electrons that are being accelerated by the linear accelerator, and it also shields the MRI from interference from the LINAC. This is just a couple of cross sections showing the design. But perhaps more interesting would be to discuss what does the MRI-guided adaptive radiation therapy workflow look like, right? As I mentioned, for conventional radiation therapy, the patient comes in typically about a week before treatment for a planning scan. After that, our dosimetry team will spend a lot of time tailoring a treatment plan specific for that patient, right? Radiation therapy has always been at the forefront of personalized medicine. Every patient gets a handcrafted treatment plan specifically for them. But that treatment plan has been based on a snapshot of the patient's anatomy at the time of their planning scan. Then when the patient comes in to receive their treatment, which is typically split up into somewhere from 5 to 35 or 40 treatments, that plan is that plan that was done based on their planning scan is delivered every day. And we use some imaging just to try to make sure we get the patient into the same position as closely as possible. But we're limited in our ability to adapt for any changes. With MRI-guided adaptive radiation therapy, our patients still receive a planning CT, or we do have some MRI-only workflows where we can eliminate the need for a planning CT. But pretty much all of our patients also will receive a planning MRI done on. We have an MRI simulator, which is an MRI scanner that's set up with lasers and other things that simulate so that we can scan the patient in the treatment position. We still do a reference plan, a pre-plan based on that image so that we have a starting point for the daily replanning. But then when the patient's set up, we take an MRI of the day. At that point, we register the MRI of the day to the planning image. And from there, we can split the workflow. We have two choices as to which workflow we select, and we're going to make that choice based on that initial imaging. Adaptive position is if there's not that much need for the patient to be for changes to the plan. We can do a simpler form of adaptation called adaptive position that I won't spend a long time talking about. It's just for, if we get lucky and the patient sets up exactly the same and all of their internal anatomy looks very, very similar to what it did in the pre-plan, we have a route we can take to speed up the treatment so that they don't have to go through all of the typical planning steps. Which is very commonly the case, when we see that there are changes that we would like to adapt to, we can do adapt to shape. In that case, we do a deformable registration, right? So we take the scan of the patient, the reference image, the image that the original plan was done on, and we do a deformable image. We deform that image to match the MRI of the day. We use that deformable registration to take all of our contours, right? So the physician has drawn the target on the planning CT. The physician has drawn the target. Physics, dosimetry, and the physician have collaborated to contour or draw out the organs at risk. So for a prostate, we would contour the femoral heads, the bladder, the rectum, the organs nearby that we're trying to protect. That deformable registration morphs those targets so that they hopefully match the scan of the day. But often we do have to, as I said, we have to have more staff there for the adaptive radiation therapy. So we will end up, allowing our experts to go in and recontour the patient's organs so that we can update the plan. There's the treatment planning system, the same treatment planning system that we use to do the pre-plan. We have available at the machine to update the treatment plan to re-optimize it based on changes in the patient anatomy. Then after that, we take a verification scan to make sure the patient hasn't moved during this time that we've been adapting the treatment plan, and deliver the beam. Sort of went over most of this. So for instance, adaptive position, it's used for about approximately 50% of prostate fractions because the changes are fewer, assuming the patient has prepped the same way, meaning that we have them drink water so that we treat with a full bladder and encourage the patient to have a bowel movement so that they have an empty rectum during treatment. And then, for instance, when if we're treating sort of a bone met, we might be able to do 100% adaptive position where we're not really having to recontour on a daily basis. But for treatments in the abdomen, nearly 100% of patients we're finding that there are changes in the anatomy that warrant a full adaptive shape workflow every time that we treat. While we're treating, intrafraction motion monitoring, sort of when the Unity first launched, this was the motion management solution that was available. We can image 1, 2, or 3 planes, meaning we can pick between any combination of transverse, coronal, or sagittal planes to image live. And we can choose one of the structures from the plan to be superimposed over that image. So for instance, if we were treating a tumor in the pancreas, we might choose the pancreas contour as our motion structure that would outline. I can't see on this image exactly if they have the outline lined up, but we can view an overlay of the pancreas contour and then manually watch to see if the pancreas moves outside of that contour during treatment. We also then have the option after treatment to do post-treatment verification imaging, where we take another MRI just to get another full 3D scan of the patient to make sure that nothing has changed outside of the planes that we were monitoring during treatment. Or if we, for a site, chose not to do a motion scan, we could with the elected Unity, because the LINAC and the MRI are so isolated, we can take a 3D scan while the beam is on and while we're treating. Just to give a quick example of a protocol, I knew that we're going to be talking about theranostics. So that's one patient we treat at Mary Bird. We deliver Pluvicto and Xofigo for patients with metastatic prostate cancer. So I just picked prostate as a site to discuss. All of our prostate patients that we treat on the Unity typically receive a daily T2 weighted MRI scan that takes about 2 minutes. There's also a longer scan, 6 minutes, that has slightly better image quality, but we find the 2-minute scan is usually plenty good for us to see what we need to see to update a prostate plan. We deliver 36 gray and 5 fractions. So whereas these patients would typically receive 28 fractions on a conventional LINAC, so they would be coming in for, over a course of 6 weeks, we can treat 5 fractions every other day so that their treatments are done in a week and a half. And we can also shrink the margins. So whereas typically we would be using at least a half cm, at least a 5 millimeter margin if we were treating a prostate with cone beam CT guidance, with MRI guidance, we're able to use a 3 millimeter margin in all directions, except for we'll shrink it down to a 2 millimeter margin in the posterior direction to help keep the target volume from sticking into the rectum too much. Adapt to shape accounts for changes in the rectum and bladder filling day to day. And as I said, there's research being done into using a diffusion weighted scan taken every day to help guide treatments based on response assessment. So now that's all old news. Now I'm going to talk to you guys about what's the exciting new stuff that we're doing that I'm very excited about. So comprehensive motion management. This was an upgrade that just recently became available for elected Unity sites. I believe we are the 5th site in the United States to offer real-time tumor tracking and gating based on treatment gating based on tumor tracking in the United States. I think there are 6 sites now in the United States that have this live and maybe 1 in Canada, so 7 total sites in all of North America that have released this, and one of them is right here in Louisiana. Um, the timeline for this upgrade, probably more relevant for physicists or if anyone works at a site with a Unity that's going through this upgrade procedure, but we were originally supposed to go live on January 20th of this year. However, that was, how many people here are from New Orleans or from Louisiana, right? So I can't complain too much. This is my 18-month-old son, Clark, and our Mardi Gras snowman that we made. Our center was closed for a couple of days, and so we had to push back our go live. So we made good use of the time, and we treated our first patient with live tumor tracking and gating on March 11th. So the Mary Bird Perkins story so far, we're sort of a medium-sized center overall in the radiation therapy space. We're large. We're certainly much larger than the average radiation therapy clinic, but compared to my fellow speakers mentioned MSK as a site that's sort of I think I also sort of consider them a nemesis a little bit. They're one of the sites that had this technology before us. But so compared to those sites like MSK or MD Anderson, we're a little bit smaller, but we think that makes us a little bit more nimble. We have 4 physicists on the service. Physics is handling 100% of the treatment planning for these cases. So efficiency is extremely important, but by working smarter and not harder, that's how we're able to offer these things right here in Louisiana, where there is an abundance of patients who need this technology, right? That's why our program has grown so much faster than other adaptive radiation therapy programs. We've had no shortage of patients who would benefit from this technology and from physicians who are eager to use it. There are 4 different different gating strategies that can be used with this, based on tumor tracking. The first is the simplest, which is non-respiratory gating. This is for tumors that you don't expect to move much. So for instance, a prostate, if we're treating a prostate, we don't expect to see respiratory motion in the pelvis. We expect to see respiratory motion in the abdomen and in the thorax, but not in the pelvis. So what benefit does this have for treatments in the pelvis? Well, with non-respiratory gating, right, we can use a very, very small envelope around the target. We track the target in real time, and if the patient stretches in the middle of treatment, we coach our patients to stay still, but everyone's human, right? Like typically we're monitoring our patients. Occasionally a patient will stretch. Occasionally a bubble of air will move through the GI structures in the region. And before, on a conventional machine, you might not see this happening at all. Prior to this tumor tracking upgrade, we would have relied on our radiation therapists to see this on that motion scan and manually pause the beam. But with this upgrade, the system will, if it detects that any part of the target moves outside of that defined window, acceptable window, it will automatically hold the beam. There is a little bit of latency in the imaging, so it might take about 300 milliseconds for this to kick in and hold the beam, but that's certainly much faster than the human reaction time of seeing a change, reaching out and pressing a button. Breath hold gating is another, perhaps one of the ones that's sort of simple to understand. If we can have our patient hold their breath while we're imaging them, and then hold their breath during treatment, that then sites in the abdomen or thorax, we can basically remove all respiratory motion. On the Unity, the beam, by tracking the target, again, it works very similarly to exception gating. This is the strategy we would employ if we expect to see motion, but we want the patient to hold their breath to stop that motion while the beam is on. Typically, this is going to require the patient to hold their breath for 20 or so seconds at a time for multiple repetitions in order to get through a full treatment. But for patients who are otherwise healthy and have good, performance status, it is an option. We have the ability to do an 18-second breath hold scan, either a T1 or T2 weighted breath hold. That will as long as the patient really is holding perfectly still, we can get fairly good image quality. This also, though, there's no predictive algorithm being used, so this is subject to about 0.2 second 0.2 to 0.3 seconds of latency. Free breathing respiratory gating. This is where, when we're doing our treatment plan, if we do, say, a 4-dimensional CT where we generate an image of the patient we break the breathing cycle up into 10 phases and we generate an image at each of those 10 phases. Well, we can choose to contour the target on a subset of those phases, say the mid position or wherever they spend the most time. And we now expect that when the patient takes a breath, we'll pause the beam at, say, peak inspiration and peak expiration, and only treat when the tumor is sort of in the middle space. This uses a predictive algorithm that uses machine learning to learn and update learn the patient's breathing pattern as it goes, and so that 0.3 second latency is reduced to nearly zero, because as it's seeing the tumor move, it knows, it's just like, if this is the image I'm seeing now, the tumor is actually really here and about to leave the motion window and then stop. And then finally, exhale gating. This is where we treat only in the only when the patient is in the full exhale phase. To do this, we use what's called a navigated scan, where we set up the MRI monitors the dome of the patient's liver and only acquires 3D data when the patient is in the exhale position based on that where it sees that diaphragm. And then with tumor tracking, we can make sure that we pause the beam whenever the patient's not in that full exhale position. So legacy motion monitoring before, sort of what did we see when we went to treat? This was sort of an odd scan, sort of unusual anatomy, but we would see basically just one outline that was, say, the planning target volume, which is our target, in this case a prostate, with some margin added. We could see the image updating live underneath, but the contour that's overlaid on it is static. With CMM, now we can track 3 structures. We'll have a display of 3 structures at once. The target structure is what we're treating. The registration structure is often the same as the target structure, but if the target is not visualized very well on the balanced, the cinematic MRI, we can use a surrogate structure that we would just call the registration structure. So for instance, a liver tumor, if it shows up really well on our planning T2, but then on our balanced cinematic scan that we take to track, if the tumor is a little bit less visibly apparent, but it's near the dome of the liver, and the liver is solid, so pretty much the entire liver moves, at least together, we could track the dome of the liver. And then finally, the envelope structure is much like what was displayed before, a fixed structure that says when the target is inside this envelope, you treat, and as soon as it clips the edge, we hold the beam. So part of what's the ongoing research in this field is figuring out, for certain specific cases, what's the best surrogate structure to use. But that's perhaps getting into a little bit too much detail. Some of these slides now are getting be more relevant for physicists, so I'll just go through them quickly and then take questions. But anatomic position monitoring is the name of the module that is actually tracking the target. The anatomic tolerance check is the name of the algorithm that is comparing the measured location of the target and determining if it's inside or outside of the treatment window. We have the ability to change our criteria on the fly. If, for instance, a patient is exhibiting a little bit more motion and the physician, we don't want to be locked in. We don't want to be in the middle of a treatment. The physician, needs to treat, but we were a little too aggressive and initially saying that we were going to require that target stay perfectly still. We have some ability to make changes to our tracking strategy on the fly. And this is just, again, more relevant for sites that are trying to implement this technology, describing our nomenclature that we're using, since as this is being implemented and there's not a lot of guidance available for sites that are implementing this, we're trying to communicate as well as we can with other adaptive radiation therapy sites. So I'll go ahead and skip ahead. I think I'm kind of at time, so move ahead to my. This is sort of relevant. So simulations, what planning scans do we need in order to deliver a respiratory gated or treatment? So for the non-respiratory strategy that I talked about, where we are expecting a tumor to stay still, there's no real changes. So that's great. That's sort of the easiest one to implement. But if you're trying to do respiratory free breathing, or any of the respiratory gating strategies, you really need a 4D CT. And at Mary Bird, we're requiring actually a 4D CT and a 4D MRI, because the 4D MRI lets us really actually visualize the motion of the target much better. Here's an example of a frame of a 4D CT for a liver patient. You can maybe kind of vaguely see a little bit of density difference there where the tumor is, but it'd be very hard to draw a boundary versus on a 4D MRI. And let's see if I can. Right, okay, and unfortunately the video won't play, but by acquiring a 4-dimensional MRI where we get an MRI of the patient in the various breathing phases, we can see the target much better, and really say if we're going to treat only on the exhale phase, we can outline it there. So hopefully this works. Before we actually beam on, we want to make sure that the system is tracking a target well. So here's a quick video showing for a prostate. This is a volunteer. It's perhaps a little small. Unfortunately, I can't get a good screen recording, so I'm having to rely on cell phone. But you can see that maybe you can tell that this image is updating live, and that the prostate target is moving slightly, but it's never leaving that window. And so one of the great things about an MRI-guided treatment machine is that we have that ability to image volunteers. Most of the data I'm showing here is from volunteers. This is a volunteer that we did a mock liver scan on. The patient doesn't have a liver tumor, but we were able to find some feature of the liver that was visible on the scan and track that and use that for tracking. So this would be an example of exhale gating. So you can see it is tracking that little feature of the liver, and the patient, for the most part, there wasn't a ton of respiratory motion, so it often didn't. The patient could take a small breath, and the target would not leave the treatment window. But you can see on this video when they take a large breath, and then when that number in the bottom right lights up yellow, that indicates that if this were a real treatment, the beam would be held when the target moves outside of that acceptable envelope. Pancreas, like I said, a common site that we treat, and even if we can't exactly visualize on the cinematic scan the tumor itself, if there is a solid tumor, we can usually at least visualize the pancreas head very well, and so we can track based on motion of the pancreas. This is an example of a respiratory average where there wasn't a ton of respiratory motion for this patient, so we expect nearly 100% duty cycle. You can see that you can see the motion there in the video that just played. There is some motion, but the pancreas is not leaving the window, and so this treatment would continue. What equipment do you need? So in addition to if you have the Electa Unity, in order to test all of this, you need an MRI-compatible motion phantom, something that has either an anthropomorphic, something that mimics a patient and human anatomy, or even just right. So Sun Nuclear makes this Zeus Phantom. Quasar, or a company called Modus makes the Quasar MRI 4D motion phantom, and they have an MRI safe motor so that we can have a target that we can track, and it moves it around inside this larger phantom, and we can use that to test the latency of the system, to test the accuracy of the tracking, and to by inserting dosimeters, either an insert where we can put an ion chamber or a piece of film or something into the target, we can actually do dose measurements to really give confidence that the dose is going exactly where we expect it to, and that the beam is shutting off when the target is not in the treatment position. Here is a video showing some of that. So you can see that's the software that is the Phantom software that is tracking the position of the target in the Phantom, and then live image that we're able to take on the MRI. As I mentioned, sort of like one of the great things about this is that we can have volunteers that we can do really realistic because there's no ionizing radiation from the MRI. We're able to do realistic mock treatments where we don't actually deliver radiation, but we go through the whole workflow with volunteers. And the QA is only going to be interesting to physicists. So just to skip to the end. If you're implementing a motion gating strategy for radiation therapy treatments, right, you really need to have the entire workflow planned out. You want to make sure you have steps in place if the tracking fails in the middle of treatment, and what do you do? Don't want to be caught on the fly. And sort of the major topic right now that's being discussed amongst sites that are implementing this is what's the best thing to track for different sites. So in the liver, how do we, if you can't really visualize the tumor on the cinematic MRI, what can you do? What surrogate can you track that's going to let you track that tumor motion reliably? That's all. So that's all for me. Thank you so much.